if people believe that marijuana is healthy and safe and there's no untoward side effects and it's not a big deal, then more than likely, as that narrative begins to penetrate the public consciousness, you're going to see a change in behavior. And that's what we're seeing. So this is from October 2015, a headline from an article in the CNN website. Marijuana study, number of Americans toking up doubles in 10 years. So marijuana use overall is on the rise. And when you look at the laws are changing. So this is the most recent one that I accessed governing.com, August 17, 2016 to get this. And this is where we stand right now as far as marijuana laws in the United States. The gray doesn't have a medical marijuana law. The dark green has some form, and they're really diverse, so they range in all different things, some form of medical marijuana law. And then the bright green has recreational marijuana. Interestingly, every bright green state, all four of these states, started with a medical marijuana law, and that's something else that we'll discuss here in a little bit. The other thing that you need to know is this: it's big business, big business. So in February of 2016 on Fortune, they had this headline: legal marijuana sales could hit $6.7 billion in 2016. The estimates are that if it goes legal in all 50 states, the first year it's legal, it'll be a $40 to $50 billion industry. Right now, cigarettes are $66 billion. So there's nothing, now, if it's a big industry, that's not necessarily a bad thing, okay? But you need to understand that there are big dollars involved in this debate, and there are people with very deep pockets who are investing heavily in this. Let me give you just an anecdote. I was out in San Francisco. I went out to San Francisco purposely to look and talk to investors and VCs and startup companies who are out there in health technology and healthcare innovation. Wasn't looking at the marijuana issue at all. Met with a number of people and overheard a couple of conversations about people talking about marijuana and industry and investing in industry. And it's, kind of a side thing. But towards the end of my visit in San Francisco, one of my friends who's out there, he's a fascinating guy, he's a Harvard grad, he speaks fluent Mandarin Chinese, and he's involved in really big time dollar investments. And we were sitting there, at lunch or whatever, and I said, Alan, you're always doing interesting things, what's your next big project? And Alan, who is very conservative in every way, said, next month I'm going to a marijuana conference. And I said, that really surprises me, Alan. Why would you go to a marijuana conference? And he said, because Greg, I'm responsible for a lot of money, and I need to do due diligence, because if there's money to be made, I need to look and see what's going on in this industry. I don't feel like I'm doing my investors a good service if I don't at least look. The only reason I mention that is this, that there are billions and billions of dollars going into this industry. There's a lot of money exchanging hands. So just remember, when we talk about marijuana and medical marijuana, a lot of people, the image that they have is, the person out in the hills that is growing one or two marijuana plants, and why are we persecuting them? Big tobacco is, we'll show this in the next slide, is poised to get into this in a big way, but even if they don't, there's a lot of money that's exchanging hands and being invested in this industry. Okay, USA Today headline, this is April 2015, will big tobacco become big marijuana? At the conclusion of the article, the author says, yeah, I think so, basically. But the point of this is this. Big tobacco, when they did the lawsuits, when suing the cigarette industries, as part of the lawsuit, they obtained decades worth of memos and emails and letters back and forth within the tobacco industry. One of the things that they came across was there were memos and letters and meetings in the early 70s that the tobacco industry executives were already starting to discuss how they could get into marijuana. They've got the technology, they've got the marketing know-how, they've got the deep pockets. They could flip a switch and take over the marijuana industry tomorrow if they wanted to. Now, people said, well, if they can do that, why haven't they done that yet? A lot of people believe that the reason they haven't done it is because of the legal risk at this point in time. They've already been sued once. They've lost $1 gazillion in their lawsuit. They're not going to go into this unless they feel like they have a pretty solid foundation legally, but they could flip a switch and easily take this over. And it's not just me saying this. There are organizations that have actually been founded. This was one founded by former U.S. Rep. Patrick Kennedy, the son of former Senator Teddy Kennedy, so obviously not a political conservative. But the tagline here, you can see, if we're not careful, the marijuana industry will quickly become the next big tobacco. All right, so that brings us to our state. And so we've talked about sort of a little bit about the ballots. We've talked about the national narrative that's going on and kind of what's happening nationally. So then there was this headline, you can see this brilliant guy here, handsome gentleman here giving this, great oration on medical marijuana. And the headline is, Hutchinson medical officials say marijuana is not medicine. And instantly when this came out, my Twitter feed went bonkers. People just, from all over the place, how can you be so foolish? You're an idiot, and even more. Voicing their opinion on how could the Surgeon General of the state say marijuana is not medicine, even when you have other people saying it is medicine. And someone actually brought up Sanjay Gupta, which I'll mention in a little bit, and I actually agree with the vast majority of what Sanjay says. Now I'm going to try to let y'all see this if it works. If it doesn't work, we'll just go to the next slide. Hold on just a second.
Should a vote decide what is medicine? All other medicines prescribed by doctors are approved through a rigorous medical process, not by the public or legislators. We need to know if a drug will do more good than harm, or if it actually performs better than a placebo. We need to know how a drug will interact with other medications, the correct research dosage for each health condition, and the side effects and long-term consequences a drug may have. These things are determined through numerous double-blind clinical trials in order for the patient to have the best possible outcome for their health condition. Rigorous research is being conducted on cannabis-based medications. Some positive results of these studies on certain components of cannabis have recently been released. If these positive results continue, approved medicines will likely start being available at pharmacies across the nation as early as the beginning of 2018. Research that approved medicines should be covered by insurance, which is not possible with medicine that is voted in and sold at dispensaries by bud tenders. Each of the 4 states, Colorado, Washington, Oregon, and Alaska, who have legalized marijuana, started with marijuana sold as medicine. Big marijuana is using similar tactics as big tobacco, profiting on addiction and normalizing use. Cannabis, medicine, and commercial products include edibles such as candies, cookies, and pop. Products very enticing to children. Other so-called medical and commercial products include high THC concentrates such as oils, waxes, and shatters for vaporizing and dabbing. THC is what causes the high. THC levels can reach as high as 99% in some products. And plants have been genetically modified to have up to 30% THC. Vastly different from the 1 to 3% THC marijuana from the 60s and 70s. Please think about it. Medical decisions that are determined by science will reduce the unintended consequences that affect our youth.
Okay, so the reason I wanted to show that is it gave a good overview, but the take-home point is simply this, is if you're going to call something medicine, the reason that we have strict laws in our country, the reason we have an FDA approval process, the reason we have those stringent criteria, is the public, when they hear medicine, there's a certain level of safety, efficacy, and also trust that goes into that. And so if you're going to call something medicine, then you need to be able to say that this has reached a certain threshold of safety and control, and I don't believe that marijuana the plant has. Now, however, there are compounds in marijuana that can be used in a medicinal way. We're going to talk about that in just a little bit. But the point is that if you call something medicine when it's not, when it hasn't achieved that and gone through the FDA approval process, it can be very problematic. So the correct way to do this, and this is sort of my official position is this, is that there are compounds within the marijuana plant that have potential for medicinal value, but the plant shouldn't be called medicine. So people ask me, well, why, what is that a big deal, or how do we do this right, or whatever. This is the correct way. This is a picture, a painting I took, a picture of a painting I took in the country of Zanzibar, and the artist there was a real genius. They painted the Anopheles mosquito here, which is the carrier of malaria. And they pictured, he drew a silhouette of a woman, a child who's pregnant, and a small child who are the targets for malaria. Those are the people who suffer most with malaria. And then he had it in front of a silhouette of a graveyard there, which is a real stark reminder of the scourge that malaria is. So malaria is a big deal internationally. About 40 million people worldwide have HIV. About 400 million have malaria. It's a big, big deal. And still, after all the research that's happened, after all the pharmaceuticals, after everything that's been done, one of the best drugs that we have for malaria is the drug quinine. Quinine is a compound, or a drug that was produced from a compound found in the tree bark of a tree that grows in Peru. And actually, it was native healers that originally found this. So hundreds of years ago, the natives were putting tree bark in certain types of teas if you had a fever. And some enterprising scientists got a hold of the tree bark, isolated the compound, and found that this compound was excellent for treating malaria, and it's still one of our best drugs. That's what we should be doing with marijuana. We should be studying it, we should be isolating compounds, we should be purifying it, and we should be giving it in a dose that is safe for patients, that doesn't have side effects, and helping people who are suffering. And I'm totally in favor of that. Sanjay Gupta, he's totally in favor of that. Matter of fact, the only thing that he has said that I haven't said is that he's very much in favor of rescheduling at the DEA level. And since I'm not part of the DEA or a national or federal agent, I don't really feel qualified to say that. But he and I agree very closely on where we stand on marijuana. Okay, so but is it happening? So people say, well, yeah, but pharmaceutical companies will never do that. There's actually 3 products out now that one's been around for a while. Marinol's been around since the 80s. It was designed to help with the wasting syndrome for AIDS patients and the nausea. And then there are 2 new compounds. This is GW Pharmaceuticals out of the UK. They've produced Sativex, which helps with muscle spasms, and then the Idiolex, which is a concentrated form of the CBD oil that is used for pediatric seizures. And we'll talk about why that's important. But it is happening, and this is the way we should do it. You know, marijuana, the plant, just because people said it was bad, doesn't make it bad. We should be taking the plant, and we should be using it and squeezing every bit of medicinal value out of that plant, and then we should be using it to help people, whatever their issues are, and trying to help the suffering and alleviate the pain or whatever problems they're having. But on the flip side of that, marijuana as a plant, as a whole plant, is very different. So the non-pharmaceutical grade marijuana products, and these are things like the edibles, these are things like the things that you can smoke or vape. They aren't FDA approved, they haven't done the research, there's no robust data on the safety or efficacy, and they have wide variations in concentrations and proportions of the various cannabinoids. All right, and the 2 big cannabinoids that I'm sure most of y'all already know, but we'll highlight just for a second, is cannabidiol, CBD, and then delta-9 tetrahydrocannabinol, which is THC. And what's important about when you look at this is there's hundreds and hundreds of compounds in marijuana, the plant, but these are the 2 big ones, and THC and CBD often have opposing effects on the body. So if you have THC that's working to give you the high, the CBD helps mute that and kind of gives you a calm or a slow burn, so to speak, on the THC. Now this is an important graph to look at. This was, I talked to a clinical toxicologist and emergency physician at the University of Colorado, Denver, and he had put together this graph. The average THC and CBD levels in the US from 1960 to 2011. So the red line is the THC level. Now this goes up to 2011 here and back to 1960. The blue line is the CBD level. Okay, so THC is the psychoactive ingredient that gives you the high. CBD is the non-psychoactive ingredient that acts somewhat as a buffer. And as you can see, the THC content is steadily rising. In Colorado right now, they've been pulling things off the shelves and doing some research on it. And what they're finding is that in Colorado, the percent is actually way up past this. So this has it up around 12% here or 11%. Actually, it would be past the roof. So the THC content on a lot of the strains in the stores in Colorado and then on the street is actually 23.7%, and it's up to 36% in some of the strains. Now that's not the synthetic stuff, like the concentrated synthetic marijuana. That's in the joints and the edibles. All right, that's important because when you look at the THC and you look at CBD, when people talk about, well, I smoked marijuana back in the 60s or 70s or whatever, we're talking about something that's a very different drug. It's much more potent now. All right, so let's jump to the research. These are 5 of the things that people always talk about when we talk about the marijuana research and what is involved, and does it help or does it do anything. So let's go through these real quickly. The first one is glaucoma. Now, glaucoma is a disease that has increased pressure in your eye. So anything that would lower that pressure in your eye would seem to help with it a little bit. So I've talked to some ophthalmologists about this. I pulled the original research. This was a great paper that was in the New England Journal of Medicine by Nora Volkow and some others. But this is a quote directly from that paper. Early evidence of the benefits of marijuana in patients with glaucoma may be consistent with its ability to affect a transient decrease in interocular pressure, but other standard treatments are currently more effective. So if you have glaucoma and you have a choice between medical marijuana or the eye drops or drugs that you could potentially use, What they're saying is that, yeah, it'll drop your pressure transiently for a little bit, but it's not going to be nearly as good as the things that you're already using. So glaucoma is something that people have said it could possibly be used for, but the data isn't there to support it. Okay, let's look at this one. AIDS-associated anorexia and wasting syndrome. This is from the Cochrane Library, which is a very highly reputable research group. And it says this: despite some jurisdictions making allowances for the medical use of marijuana by patients with HIV and AIDS, evidence for the efficacy and safety of cannabis or cannabinoids in this setting is lacking. So what they're saying is that, yeah, people have used it. Yes, some people say that it helps. But when you look at the research and you actually go deep into this subject, it's not as good as it sounds. What about PTSD? This is another one. And of course, all of us want to support people who've been in our armed services. You know, it's a tragedy what's happening with people serving overseas, coming back, and you look at the VA scandal and all that, people not getting the care that they deserve. I feel very strongly about this issue. I've taken care of veterans my entire career, and if there's one group of people that I really feel like deserve excellent care, you know, it's the veterans. Matter of fact, I've actually you know, said to many people, what we should do with our veterans is we should give them the same health care that Congress gives. Just make them, you know, open that up. Anyone that serves as a veteran, just give them those benefits and allow them to go to any hospital that they want to go to get the care that they need. But when you look at medical marijuana or marijuana, this is out of the Journal of Clinical Psychiatry. This was a study done of over 2,000 veterans who were suffering from PTSD symptoms. And this is a big deal. Post-traumatic stress disorder affects people in a very severe way, and we're looking all the time for ways to make this better. But look at this. In this observational study, initiating marijuana use after treatment was associated with worse PTSD symptoms, more violent behavior, and alcohol use. So not only did it not help, it actually contributed to worse outcomes. So it's not something that if I care for veterans that I'm going to allow, I'm going to recommend to them. Then you have this, cannabinoids for epilepsy. This is a big review done by the Cochrane collaboration. Now this is another big issue. So a lot of people feel very strongly about this, pediatric seizures and marijuana. And so this is the take-home point I want you to get. We're going to talk about this slide in just a second, but I do believe that there are compounds within marijuana that can be used in some cases to help pediatric patients. But the way you do this is you concentrate the CBD oil and you give it to patients that need it. You don't have kids who are 4 or 5 years old smoking marijuana joints. That's not how you deliver the marijuana components to kids that have these pediatric seizures. So there are 4 randomized controlled trials. That's the gold standard for medical research. A total of 48 patients, only 48 patients were in those trials. All reports, this is their words, not mine, low quality. And anti-epileptic drugs were continued in all studies. So it wasn't that people controlled it and took all these kids off of their epileptic studies and then put them on marijuana, oil, or anything else. They continued all the anti-epileptic drugs and then added to it. And what they found was that there were no adverse effects, so that's good, but no reliable conclusions can be drawn at present regarding the efficacy of cannabinoids as a treatment for epilepsy. They said it was so varied, it was so poor quality research it couldn't be done. Now I believe that there is some promise here. There are a number of case reports in the medical literature that CBD can be an effective treatment for pediatric seizures in certain cases. And the way you do this, though, is you concentrate it and you make it more available. So here's another map of the marijuana laws. We showed one map earlier. This is the map of the marijuana laws, and it includes something that I think is very interesting. All these green states that you see here, they all have passed oil, pharmaceutical grade CBD, more available to people in those states. You know, I find a hard time arguing against that. I think that's actually a very good thing, as long as the CBD oil is something that's purified and it's high grade and it's high quality, and that people who are using it are actually getting what they think they're getting in that oil. What you want to make sure is that it's something that's done right, because otherwise, if you do it in an impure manner, you could be giving kids things that are mixed up with pesticides and everything else. But as long as they're getting CBD oil, the real stuff, that's a good step in the right direction. And these states have already done that. I've actually been contacted by a number of legislators already here in Arkansas who are interested in passing a law that would make CBD oil more available for pediatric patients. So hey, it looks like people are doing their research and that they are trying to think outside the box and maybe make this more available, which is a good thing. Okay, and the last issue is the pain issue. So if you look at this, this is the percent of people, all the people in the Colorado medical marijuana group. So anyone who's qualified for medical marijuana in the state of Colorado, in their qualification for medical marijuana, they had to say, it had to be documented why they were getting it. So now these numbers don't add up to 100%, it goes over because some people have more than one symptom or more than one diagnosis. But if you look at this, okay, this is everyone in the state of Colorado that qualifies for medical marijuana. Cachexia, which is the wasting syndrome, you can't eat, you're too skinny, you're anorexia, you need to eat more. 1% said that was the reason they got marijuana. 1% for glaucoma, 1% for HIV/AIDS, 2% for seizures, 3% for cancer. So that's a very, very small percentage of people in Colorado who are qualifying for medical marijuana. When you get to nausea, you get to 10%. You get to muscle spasms, it's 15%. 93% of the people in that group said that pain or severe pain or chronic pain was why they were qualifying or why they were interested in medical marijuana. All right, so I became famous a few weeks ago. Did anyone see this cartoon? Okay. One person, good. It wasn't very flattering of me, but I thought it was really kind of funny, so I'm including it. So when we talk about the opioids versus marijuana, this appeared in the Arkansas Times just recently, and I'll read it to you. Arkansas Surgeon General on medical marijuana. So you have this gentleman here. Sir, this plant can help relieve pain, nausea, and PTSD for the chronically ill. And then here I am holding this huge bottle of OxyContin, and I say, it's not safe. A chronically ill patriot knows we need to support our opioid. They've misspelled opioid, but that's okay. Corporations. And then I say, and by the way, you're under arrest. So my wife and kids thought this was very funny, and a friend of mine actually edited this so only my face would appear on his phone every time I called him. So it's making the rounds amongst my social group, and much to my chagrin. But anyway, so this is something that's come up over and over and over again. And again, I want to be very transparent and also just let you guys know how passionate I am about this opiate issue. I was in training 20 years ago. I was told that opioids were not addictive, that people were suffering, and that we need to aggressively push these opioids out. And now here we have this incredible problem with the opioid epidemic. And so people are desperate trying to figure out how do we get people off these prescription opioids and onto other things. And I think that's a very good question to be asking. But the problem is that in discussing marijuana and the opioid issue, I think the desperation and the passion people feel about the opioid epidemic, sometimes the details of these research papers get lost. So this is a big paper. Most people who've been involved in the marijuana or opioid issue at all know this paper. It's been tweeted to me multiple times, emailed to me multiple times, and in a lot of popular lay press. And so this was something that appeared in JAMA, which is a good article, a good journal. And the title of this is Medical Cannabis Laws and Opioid Analgesic Overdose Mortality in the United States, 1999 to 2010. So what these people did was they took all the opioid overdose data from a statewide level. So they went to one of these big databases and they looked, and they said, okay, if you've passed a marijuana law, does that lower the overdose rate for these states? And the end result was, yeah, it did. A little bit, but just a little bit, but it did look like it might have had some effect. So people have jumped on this and they've said, this is how you solve the opioid epidemic. We allow people to use marijuana, they can switch off of the opioids and then they won't overdose. Which again, I'm not in favor of overdoses. I think those are terrible drugs. But I have a problem with that conclusion. And here's the problem I have with that conclusion. First of all, Washington State and Colorado, the two of the most liberal marijuana laws in the country, have two of the highest opioid overdose rates in the country. Number two, if you have ever been addicted to opioids and you try to switch someone off of an opioid like heroin or prescription drugs or morphine or anything like that, and you try to put someone cold turkey on something else or try to gradually get them on something else, it's very difficult. The way to get people off of opioids is to sort of transition out and offer something that that reduces those cravings and yet still helps with the pain. Marijuana doesn't reduce the cravings from opioids. Number three is this, is that you're looking at a high level, huge database that there's no way you can control for confounders. The first thing they teach you in any statistics class is that correlation does not equal causation. So there are a lot of tall people who play basketball. That doesn't mean that basketball makes you tall, okay? So that's the general, layman's terms when we talk about statistics. It's the same thing with this. There's a correlation, which means a little bit lower overdose death rate in these states that have passed marijuana laws. That doesn't necessarily, it could be that marijuana is contributing, but that doesn't prove anything. It just proves that there's a correlation. And the last thing I would just say is this, is that let's say some brilliant scientist was able to figure out a way to show that yeah, it does. It's marijuana that it's making a difference, and it's actually it's preventing people from going on the opioids or whatever, and it's actually contributing. The big question that you need to ask is, okay, but is marijuana doing something on the back end that would be just as bad or worse? People focus on the overdoses for opioids, and it's a big, big deal. I've lost count of the number of people I've resuscitated from overdoses of opioids. I've lost count of the number of people I've had to go out and tell your husband, your wife, your spouse, your child, your father and mother is dead because they overdosed on opioids. It's a big, big deal to me. But the fact of the matter is that if you offer someone something and on the back end of it, it causes more problems for not only that person, but for the community, all you're doing is you're changing the problem, you're not solving the problem. Let's go to a different paper. So this is one that just came out a couple of weeks ago, and again, as soon as it hit, I started getting media inquiries, tweets, emails, and this one came out, State Medical Marijuana Laws and the Prevalence of Opioids Detected Among Fatally Injured Drivers. So what these researchers did was they took all the states that had medical marijuana laws, and then they looked at fatal car crashes and to look at the rates of people that have positive opioid tests, thinking that, you know, we'll see if there's been a change in what drugs people are using. And what they showed was, in the 20 to 40-year-old age bracket, that there has been a very small reduction in the number of people testing positive for opioids in states that have passed medical marijuana laws. So what does that mean? Now, instantly, when this hit the press, you had people who were writing blogs, and they were in the media, and they were texting me and emailing me saying, this proves we need to have medical marijuana laws because it would help with opioids. Now again, what does this prove? Number one, there's a correlation. Number two, all the other criticisms of the prior paper. And then number three, the interesting thing is that they still wrecked their cars and killed themselves, okay? So something was going on. What's really interesting about this paper is that if you look at the list of people who wrote this, here's all the authors here. When you write a scientific paper, the person who does the most typing and the most physical labor is usually the first person here. And this is June Kim. June Kim is a student who's trying, I think he's getting his doctorate in public health. But the person who is the most senior person, who's the advisor or mentor to the research group, is always listed last. And this is Awa Lee, who's an MD who also has a doctorate in public health. Now what's interesting is that as soon as I saw this, I thought, well, that's really great, because Dr. Lee is one of my best friends. He was my mentor at Johns Hopkins. We wrote a number of papers together. And so I had his email address, and we've gone back and forth, and I've also been emailing back and forth with June Kim. So at the end, when I asked Dr. Lee specifically about the paper before that I mentioned, and then also this paper, and I said, what do you think about medical marijuana? And he said, what his quote was that there is no evidence that medical marijuana, or marijuana in general, is going to solve the opioid crisis. It's just not there. So Dr. Lee is an absolutely brilliant guy. He's an endowed chair at Columbia, and just a great friend. So it was good to get that input from him. Okay, the other paper that always comes up when people are talking about the marijuana issues and how they could possibly help is this one. This one appeared in Health Affairs earlier this year. Medical marijuana laws reduce prescription medication use in Medicare Part D. So what this group, this couple did, this is Ashley and David Bradford. She's a student in the master's program there at the University of Georgia. Her dad is the chairman of the department. They co-wrote this. And what they said was that when they looked at the data and how prescriptions were being filled and the cost of Medicare, looking at all the different states, the states that have medical marijuana laws seem to have a little bit of savings. Now the savings was half of 1% in Medicare, so 0.5%, so it's very small. But they said, well, this shows some promise. So again, I'm a public health person, I'm all in favor of saving costs, but this misses the big picture. And this is a perfect example of why in academics, it's very important that you chase down ideas that actually mean something in the end, practically. This is an interesting finding. Again, it's correlation versus causation and all those other criticisms. But the big criticism I have for this paper is this, and the problem is that this doesn't talk about anything about the outcomes of the patients who switched off of their drugs, if they did that, and went on to medical marijuana. So let me give you just a real, just crude analogy to this. What if you picked up the paper or you read on a blog that someone was mixing some mixture of dandelions and cat spit and dirt, and blending it all together and selling that on the internet and saying it could cure cancer and it could do this and it could do that? Well, the big question would be, before anyone decided to make that legal, would be, does it actually do that? Does it help? And as a physician, if I found out that half of my patients were not filling their prescriptions and were switching over to this, mixture of stuff that this guy had, cooked up, well, yeah, it would save them money, it would save the healthcare system money, but the big question I would want to know as a physician is it helping them? Because if it's not helping them, if it's actually, keeping them from taking something that they need to cure them of their problem or to manage some problem, that's the bigger question. And that's something that gets lost in the discussion of all this. It's great that we're lowering costs, but lowering costs is a spoke of the wheel when you talk about healthcare issues. The target, the center of the wheel, should be taking care of people. If you're not taking care of people, at the end, it doesn't matter how much money you're saving. You're not fulfilling your mission. All right, last couple slides on the opioid epidemic. This was something, I've mentioned this already, it's a catastrophe. And if you look at the history of the opioid epidemic, what worries me the most is the history that 20 years ago we were taught one thing that was based on scanty research, and that scanty research was pushed out, and there were big problems because of it. And it's a great example of how you don't want your health policy to be based on. Okay, now just real quickly, we're going to run through these slides. Marijuana safety, because everyone always asks, well, is it really safe? Number one, it does cause dependence, especially in adolescents. When we look at the marijuana research, and we say adolescents, anyone under the age of 25 falls into that category. So we don't often think of people being adolescents at the age of 20, 21, 23. I mean, they're serving in the military, they're very independent. It's not what people think of. Anyone under the age of 25 falls into that adolescent category for these research papers. This is a paper in addictive behaviors, and it says adolescent onset of cannabis users were an estimated 2 to 4 times more likely to experience clinical features of dependence. 1 in 6 people under the age of 25 who experiment with marijuana eventually develop a dependence. And the other thing that is interesting about this as far as use, and thinking back to the national narrative, as risk and disapproval in our culture go up regarding marijuana, use goes down. As risk and disapproval go down, use goes up. So adolescents are responding to this national narrative, and I think much more than the specifics of what we do in the States. Point number 3, it does contribute to motor vehicle crashes. This was in epidemiologic reviews just a couple of years ago, and fatal crashes. And the biggest problem I see is this. Cessation, so you have a longitudinal study. They tested people in their the neuroscience testing, so their intelligence testing and all that at the age of 13 and then later at 38. People who used marijuana, they tested them before they started using, and then later at the age of 38 after they stopped using. And what they found was that even if they stopped using, if they've used at least once a week, and they stopped using later, cessation of cannabis use did not fully restore neuropsychological functioning among adolescent onset cannabis users. That's very important, because we used to think that if you stopped smoking marijuana, this stoner affect went away and you came back. What they're showing is that, no, that's not the case. If you're habitually using marijuana and you're under the age of 25, the chance of you going back to your full intellectual ability is very, very low. Okay, psychiatric effects. If you're using marijuana, you have memory impairment that lasts at least 7 days. You can have acute psychosis, so psychiatric breaks where people are actually getting violent and assaulting people because they've taken and ingested some these really high potent products. And then lastly, depression, which is why Patrick Kennedy, obviously not a conservative guy, says he's against medical marijuana legislation and against legalization of marijuana, because how can you have, he's a big activist for mental health issues, and how can you support something that's actually going to worsen the mental health of communities, and he doesn't feel like he can do that. Last few slides here, marijuana use associated with other substances. This is correlation, not causation. There's a correlation between people who have heroin abuse and people who have used marijuana. They're 3 times more likely to try heroin, and this is a big one here. So this was in the Journal of the American Academy of Child and Adolescent Psychiatry. Approximately 74% of the adolescents in Colorado's substance abuse treatment programs had used someone else's medical marijuana, and they reported using diverted medical marijuana a median of 50 times. So just in summarizing the effects on adolescents, it causes addiction. 25 to 50% of those who are daily users become dependent. Altered brain development, it does something to rewire the developing brain under the age of 25. Poor educational outcomes with an increased likelihood of dropping out of school. Cognitive impairment with lower IQ. Those who are frequent users during adolescence. Diminished life satisfaction and achievement. And then you have the symptoms of chronic bronchitis and things of that nature. Other unforeseen consequences. This was an article that just appeared just a few days ago. Marijuana labs spawned lethal explosions across the country. So increasing the amount of CO2 in an indoor grow lab helps the plants grow, but also if you're using other gases to pump out those the CO2. So these growers don't want to tap into their natural gas lines because then the gas companies come over and start checking on them. So they use butane and propane, and that can lead to this. The other thing is that marijuana is not federally approved, so no bank will give these corporations a bank account. So you've seen an upsurge of private security companies and armored vehicles trying to protect the stacks of cash that go through these dispensaries. And then lastly, the precedent setting, if you don't get something FDA approved, right now we're talking about marijuana. What if next year or the year after it's some antibiotic? And a pharmaceutical company says, hey, look, it cost me $50 million to get something through the FDA approval process. It cost me $10 million in lobbying to get this passed in California. I'm just going to go directly to the people and get my antibiotic passed, and then it's legal. So we're setting a very bad precedent by going around the FDA. Last couple of slides. Here's some edible products that are in other states. So Keef Cat, Oleo, Buddha Finger, Trichrome Crunch, Munchie Way, Roster Reese's. This was posted somewhere, and someone said, well, that's a little duplicitous because that was eventually yanked off the market, and those people were sued. And the point I want to make is this: is that they were sued and it was taken off the market not because of the marketing and the targeting of certain groups. It was taken off the market because of trademark infringements. Hello, this looks just like Kit Kat, Nutella, hazelnut spread with medical marijuana. I've been told by lawyers I can't say that they're targeting young people, so I'm not going to say that. I'll let you make up your own mind. But I can tell you, I have 3 children. I showed them these pictures, and all of them said young. So it's very interesting. Gummy bears, 25 milligrams, or 25 individually infused 10 milligram pieces, so 10 milligrams of THC per gummy bear, comes in a pack of 25. Looks a lot like candy. Looks a lot like the sort of things, the sort of marketing tactics that the cigarette companies were using with Joe Camel and some of the others, and they eventually got banned. Especially this, Cannabis Cola, sold in medical marijuana states and the recreational states as well. My kids said that looks really great when I showed it to them. And Candy Care, medical cannabis. So this is something that, obviously in just the medical marijuana states could be sold. And lastly, I just want to see that this was a website that I just took a clip of. I typed in medical marijuana doctor, and this came up. Now, what's interesting about this is that I know you guys are smart people, so look at this. Get your medical marijuana card now. It's free to apply, 100% online. You pay only when you get your medical marijuana recommendation is approved. You've got a certain age group here, not a terminal cancer patient, I don't suspect, fairly young guy. And then you have this quote down here: I hate filling out forms, but with MMJ Doctor Online, made it really easy. I was done in a few minutes. So it's quick, it's easy, and there's a smiling young person there to convince you that, hey, this is A-okay. So why am I against this? I'm not against it because I dislike freedom. I'm not against it because I have some problem with people growing plants. I'm not against them. I'm not even against people who say that we should decriminalize or whatever. That's a completely different argument. And if you believe that you should be able to use it as an adult, just like alcohol or just like cigarettes, hey, I don't agree with that, but that's fine. That's not what we're talking about. What we're talking about is taking a plant that has some significant safety risks, and we're marketing it to people as safe. And kids are listening to this, other people are listening to this, and to me, that's disingenuous. So just to summarize, THC and CBD do hold promise for therapy. Habitual marijuana use is harmful to adolescents. Adolescents can obtain marijuana with parental consent with both of these measures. The law is written very broadly. So a kid who's 15 years old who has ADHD could use marijuana. That would be legal. The law binds employers and landlords, and the law uses funds for marijuana purchase with tax dollars. And I add this in my talks just because of this. I know, going into this, the vast majority of you disagree with me on this issue. Maybe I didn't change your opinion in the least. But what I tell people is this, is that it's an important issue. It's an important issue even if you feel like marijuana should be legal and recreationally used. I have friends who are adamant small government libertarians who hate the idea that marijuana is illegal, who are adamantly opposed to this because of the concerns that I just raised. And so I say, I'll just close with this. I've got Dr. Benjamin Rush was the only physician signer of the Declaration of Independence. Dr. Michael Crichton, a Harvard Med School grad who wrote all the books and did all the movies and stuff, an incredibly creative guy. And then this doctor, Dr. Seuss. So not a physician, but a really cool guy. And he summed it up like this in the book, The Lorax: unless someone like you cares a whole awful lot, nothing is going to get better. It's not. All right, thanks, guys. I think I went a little long, but I'm happy to take questions.
You got some water there, Doctor. Give him another round of applause. That was a lot of information in a very short amount of time. Put this mic where for so you guys can sit together, nothing easier on you. Obviously, we would like to take some time. We've got probably about 25 minutes tops. We'll be at 8 o'clock, and that should give time. I wanted to, before you ask a question or if you have a comment, I wanted to ask you if you learned something about the topic during his presentation that you didn't know before you came in here, if you would raise your hand, just to give that feedback. If there's something you learned about the topic that you didn't know, that's not saying you're for or against, but you learned something. I'm going to try that again because there's some of you not raising your hands, and I know you had to learn something. So how many of you learned something from his presentation you didn't know? Good number of people that learned. I think even if you're for or against, you definitely learned something because he did a good job of trying to cover all that. What I'd invite you to do is to please come up if you have a question. I know that you may stack up there if there's a few of you that have a question, but if you want to come and take the mic, and that way you have an opportunity to be heard by everyone. And if you would, to respect others and their opportunity, ask a question, and we'll have Dr. Smith and Dr. Bledsoe respond to you and try to give you an answer best that they can. It looks like this gentleman here would like you to take that. Yes, go right ahead.